Hello and welcome to NCGPA Live, informative conversations about general practice in Nottingham City. I'm Dr. Andy Foster and I'm joined today by Depak Patel. Let's bring Depak on screen.
Hi.
Hi Depak. Hello. So
Yeah.
Depak is a clinical pharmacist who works within NCGPA's Stub service. And today we're going to be exploring smoking cessation and the Stub service, which is provided within Nottingham City by NCGPA. And NCGPA is Nottingham City General Practice Alliance, which is a federation with a membership of over 40 GP practices in Nottingham City, which supports local primary care networks as well through the employment and coordination of ARS staff, in addition to providing other pan-city services. And today we're going to be covering the Stub smoking cessation service. We're going to look at the story of how the service came to be, who the service is for and how people can access the service and how other services can refer into it, what actually happens when patients engage with the service, and explore some of the challenges and positives of running the service. But first of all, introductions. So I'm Dr. Andy Foster. I'm a GP partner in Nottingham City. I sit on the NCGPA Board of Directors and I'm acting Deputy Clinical Director for Bulwell and Top Valley Primary Care Network. And now introducing Depak. Hi there, Depak. Do you want to just introduce yourself?
Yeah, so I'm Depak. I'm a primary care clinical pharmacist working in Bulwell and Top Valley Primary Care Network. And I've also been involved with the Stub service since January 2020.
Okay.
Or 2019, actually, if memory serves me right. It's been getting very confused with the pandemic. But yeah, so, and actually, I've always had a sort of interest in smoking cessation, going back to my role when I was in community pharmacy, and they did have a pilot of a smoking cessation service in community pharmacy where patients would visit regularly during the program. And you would, check their carbon monoxide and various other things which we'll touch on during this podcast.
Great. So you got a good background in smoking cessation services, which is fantastic. Yeah. So just bringing some data on screen, really, because is smoking a particular problem within Nottingham City? I think it is. So we've got more than 20% of adults who live in Nottingham City are smokers, compared to a national average of 14%. Which is not acceptable, and we all know how important stopping smoking is on our healths, and we don't need to go into that in too much detail today, because this is all about stopping smoking. And as we can see there, these are some statistics from Stoptober last year, and there are 55,000 smokers in the city. So I guess there's a lot of work for Stub to be doing there, Depak.
Indeed. As I say, we have a lot of data, especially PCN-led data that shows that smoking is a big issue amongst other health issues in Nottingham City in particular.
Excellent, yeah. And I suppose before we start talking about the service, it might be worth just acknowledging how the service came to exist. And I don't know if you were around at the inception of the service, Depak. I know I was around and involved in some of the conversations. Do you remember how it started, or?
I joined slightly after its inception, so yeah, you will know more about the how it came to be than I will.
People living and working in Nottingham City probably remember the New Leaf service, and that was always the service that we encourage patients to engage with. And unfortunately, I think there was a commissioning issue, and that service ended up being decommissioned. I think something to do with the reorganisation of budgets between public health and Nottingham City Council. There was some issue at the time, I remember, but there was a commissioning gap, and actually there wasn't an effective smoking cessation service commissioned, or there was a danger that it wouldn't be commissioned within Nottingham City, and it's such a big issue for the city that wasn't really an acceptable way to move forward. So I know that Nottingham City Council, the CCG, and Public Health England worked together with NCGPA to design the Stub service, and that came into being. And I think, was it 2019 it began, Depak?
I think it was the year before. I joined it quite soon after it started, but I joined in January 2019, and it had already been running the year before.
Okay, fantastic. Well, let's leap in then. So I think some of the key things people will want to know about the service is who is the service for? Who is suitable to access this service?
So it's for any adult, so over 18s, registered with a Nottingham surgery in the city, and is resident in the city,
Excellent.
and
And
who are motivated to quit.
and that's really important, isn't it? I suppose, and that's I guess why it's important to have people self-referring into the service, because that demonstrates that level of motivation. Patients often find it a bind. Actually, they often say, "Oh, can't you refer me in?" But actually, I think where people are able to, it's much better if they self-refer, because that means that you get to focus on those patients who are actually genuinely motivated. Which I guess brings us to the next question, really. So, how do patients get connected with the Stub service?
Okay, so we'll go back to, they can have conversations with a clinician at their surgery. For it may be just a consultation or a health check. It may be anything at all, and where smoking is discussed, and if they will always ask whether the patient will be asked if they are ready to quit, or are thinking about quitting, and at that point the discussion will lead to the service that's available in Nottingham City, the Stub service, and at that point there are two options. Either the colleague or clinician can refer at that point, or, as we've said, the preferred option would be for patients to self-refer, and they can do this by completing an online registration form on the NCGPA website, by emailing NCGPA, and they can call NCGPA. So there are several mechanisms for patients to self-refer, and as we've already mentioned, the reason we prefer patients to self-refer, because it is another indicator of motivation to quit. So as I say, those are mechanisms by which they can access the service.
Absolutely, and it's really sort of pleasing as a clinician and someone who practices in Nottingham City to hear that self-referral is the sort of preferred mechanism of referral into Stub, because I think, as you say, works much better if people are motivated, and actually that takes a bit of administrative burden off the clinician within the consultation or the reception team at the practice, and also removes hurdles as well. You described a lot of referrals coming in following conversations with clinicians or health providers. Are patients okay to approach the service cold? Do people need to go and have a conversation with their GP, or if they're feeling motivated, quick, can they just contact you guys?
Yeah, and then I think there is an awareness of smoking cessation services, but as I say, the information is out there. People are often aware of the service and how to self-refer. So they don't need prior consultation with a health provider to be referred to the service. It can be managed by themselves. And just one consideration, if people don't have access to the internet or anything like that, practices can book directly with us. The reception team can book appointments. They are able to view capacity at the service. So the service is available to all.
And I guess that receptionist booking appointments is really, really useful if people have accessibility problems, I suppose. If they're not going to be very good at ringing the telephone number or using the website, for example, then that's a really useful tool for particularly those people. But yeah, really good to hear that self-referral is strongly encouraged. And then finally, I was just wondering, actually, before we get to does it work, I was just wondering what the scale of the service is, because I do send people in the direction of Stub, but you're working across the whole city, so I imagine there must be some considerable scale to the operation. Can you give any indication of that, Depak?
Yeah, so currently there are a team of 5, off the top of my head, 5 clinical pharmacists, 3 smoking cessation advisors. There's the the reception team, the background admin team as well. Some of the smoking cessation advisors, are part of the admin team, wear several hats within the service. During a particular session, there would be a clinical pharmacist and at least 1 or 2 smoking cessation advisors, and it can always be more than that. And so there is capacity there. The appointments are available not only during traditional business hours, they're available in the evenings. Monday to Friday, but also at the weekend on Saturday and Sunday. So, trying to give patients the greatest opportunity and availability to access the service to help them with quitting smoking.
That's great. Yeah, and it's good to see that there's a range of face-to-face appointments and telephone appointments there. I know, sort of coming out of the pandemic, a lot of patients like going back to face-to-face appointments, but actually there's a large cohort of patients who really, really have enjoyed having telephone access to services, particularly things like smoking cessation, but also like some of the counselling services as well. So it's good to see that that's being kept up for those patients who want it. The other thing that I'm aware of is where you can find sort of space or capacity or estate in practices like within PCN geographies. I know that you're quite willing to put on clinics there so that patients don't have to travel too far to a Stub clinic, which is really, really great as well. So Depak, before we talk about kind of what actually happens, I was just wondering, does it work? What sort of success are you seeing within the Stub service?
Okay, so we were given data, and please bear in mind it's old data, it's not current data, and I would estimate it's around 18 months old, but we were told that our success rate at the Stub service was more than double the national average, which was really pleasing to see that, and it was testament to the structure of the service, and that we were practicing along the right lines, and the ultimate impact on patients was great, and to see that figure and feedback was really, really good to see.
That's really good. Yeah. Any thoughts as to why you're so much more successful than the national average? Any thoughts?
One particular aspect, I suppose, would be that we're all aware of the evidence, regarding using NRT in smoking cessation, and obviously the licensed prescribed products, Champix, Varenicline, and Zyobran, bupropion. But also there's a substantial body of evidence to support behavioural support with the smoking cessation attempt. So I think it's the dual approach of not only treatment, but also treatment and behavioural support that drives the success. And more often than not, during consultations, we'll go to consultation structure shortly, but the behavioural support is important in that it gets patients to think about the changes they can make. So it's not an instructive process. It's actually a very active process from the patient's perspective. And I think, it is that level of behavioral support that surrounds them during the program that helps drive that success.
Yeah, that sounds really great. And I suppose just thinking from a data perspective, it's about what you're comparing it to as well. This is me putting on my my sort of questioning, interviewer hat, and you wonder what is that compared to similar services, or is that just people trying to quit? But nonetheless, really, really great and encouraging statistic. I suppose also, I guess this has been designed as a new service, hasn't it? Relatively new, so I guess there's something about having a new, fresh design, and having potentially newly recruited, motivated clinicians as well. So, but really interesting. So, and as the other thing I was wondering about with success is how do you measure success? How is that determined? Might sound like a silly question.
I suppose you need to consider timeline in some respects. If we're taking a quit attempt in isolation, the immediate measure of success would be, has the patient quit or do they continue to smoke? However, we do see patients who maybe are unsuccessful in their first quit attempt. They do come back. They do have to wait 3 months to go back and reflect, and just think about the previous quit attempt and what can be different next time. But we do see patients return for several quit attempts, and I suppose In a longer time frame, the measure of success would be, when the patient quits after the second or third or fourth attempts. Some patients can quit at the first attempt. In others, it can take several attempts. So, and even if it's a measure of success, can always be, have you planted the seed? So whilst it may be unsuccessful initially, that patient will always have that thought process of, yes, I tried to quit, but then we'll keep on reflecting and may come to a point where, okay, I feel I'm at the right and the most perfect place now for another quit attempt. So yeah, whilst for data purposes, success can be measured as ultimately has the patient quit, but it's also helping them in that particular time in their life at that moment. So,
Yeah. So sometimes you still have that impact, nudge them along that journey towards ultimately quitting, even if that specific course of intervention with the Stub service is not ultimately successful. That doesn't always mean you've not made a difference. So that's a really good point to get across as well. Do we still need to do like carbon monoxide breathing tests now? I remember that was a thing. Must have been difficult with COVID. Is that still part of measuring success?
It is. Prior to the pandemic, the majority of appointments were face-to-face, and the routine would be first appointment, you would measure carbon monoxide reading prior to quitting, and then at appointment 2 and 3, and a stage is not necessarily every appointment, you would measure carbon monoxide reading. Subsequently, to reinforce that the patient has quit. It has been slightly challenging after the pandemic. Of course, during the pandemic, everything was virtual. So the guidance was obviously we can't measure carbon monoxide reading.
No.
Yeah. So after the pandemic, we have slowly reintroduced face-to-face appointments. And for a reason that I'm unsure of, there tends to be a high degree of patients that don't attend the face-to-face. And whether it's because there is a certain element of convenience in telephone appointments that patients have now become accustomed to and used to, and telephone appointments are convenient for patients in their busy day-to-day lives. Yeah, that's something we will, obviously continue to look at and find solutions to addressing.
Yeah, great. So I suppose what's really helpful for clinicians referring into the service and also for patients who might want to come along to engage with Stub is just understanding what actually happens to them when they come along to the service. So I was wondering if you could talk us through sort of the patient journey. So I guess someone's been referred or they've made that first step of reaching out and ringing the self-referral number or filling out the online form. What happens next, and then what happens on the course of their journey?
Okay, so obviously, referral has been made either by health provider or patient themselves. Stub is a completely pharmacist-led service. That is the agreement, the service level agreement. So yes, so the patient is immediately registered by the one of the admin team of the service, and they are put onto a new registration waiting list. Clinical pharmacists will then have time in their ledger to triage the patients. So again, satisfying the pharmacist-led criteria. And they will see whether the first consultation needs to be or needs to remain with the clinical pharmacist, or whether the patient is suitable for smoking cessation advisor to do. Our smoking cessations have been trained. They've shadowed clinical pharmacists, and they've had regular debriefs, and they are trained to complete the first appointments now, which is really good to see. Really good to see their development in that respect.
So Depak, what would differentiate between a patient who was suitable for the smoking cessation advisor and somebody who needed to have a first consultation with a clinical pharmacist?
So it could be polypharmacy, where patients are on multiple medicines. maybe complex mental health issues, pregnancy. While smoking cessation advisors can, of course, have consultations with a patient who may be pregnant. There may be issues of comorbidity, other complexities that may need, the first consultation to be by the pharmacist.
So it's really good to hear, actually, that the service will accept patients who are pregnant, for example. I guess there isn't really a good reason why not, and it's so important for people who are pregnant not to smoke. But it's great to hear that you're open to pregnant patients and people with quite complex health problems, and that there's the support of a well-trained clinical pharmacist to deal with those patients if it's necessary. Like, that's really reassuring to me as a clinician, sending patients in the direction of the service. So it's really, really good to hear. So what happens next? Talk us through.
Yes. So they will then, once they've been triaged, they'll be put onto a waiting list for either pharmacist first appointments or smoking cessation advisor first appointments, and they will get booked as appointments are released. Then they will be called, either called on the day, or the patient will attend clinic if it's a face-to-face appointment. And the structure of, and they will have a series of 6 appointments. So it'll be the first appointment, and then 5 follow-up appointments. Excuse me. And the structure of those appointments is based around the guidance provided by the National Centre for Smoking Cessation and Training. They have wonderful, training modules, on smoking cessation itself, but also smoking in pregnancy, e-cigarettes, complex mental health and things like that. So yeah, the structure is loosely based on that. And so we will talk about, what the patient's typical day smoking looks like. We will talk about, their social circumstances around them, their reasons to quit, any previous quit attempts they've made, what they have potentially tried previously to use to quit. And then, we will agree a treatment that they want to use. And agree is a really important part. The patient is involved in every decision made in the program. They almost set the agenda. And so, once we've decided on the treatment, we will then ask them to choose a quit date within the next fortnight. So, that can be quite surprising to patients, in that sometimes they don't expect to be made to choose a quit date in such a short time frame. So, but we then explain the reason why that, cutting down versus stopping altogether, there's no difference in success rates. So yeah, so we'll choose a quit date, but as we touched on earlier, the behavioral support aspect is really important. And so we will then go on.
I was going to say, let's break it down, Deepak. So, so it's really good to hear 6 sessions. So that's really good. Just a quick question: how long is each session? How long will someone spend with a pharmacist or the smoking advisor?
So we allocate 30 minutes for the first appointment, and then 15 minutes for all the subsequent follow-ups.
That's good. So lots of time to explore all of those aspects that are important to getting their head in the right place for quitting. So that's good. And then I think we were about to talk about the interventions. So I guess people might expect to receive some behavioral interventions and potentially some prescribing as well. That's often what patients are interested in. So can I have Champix? That's often what people ask. What sort of interventions might people get?
Okay. So, treatment based, obviously. We have, the full range of nicotine replacement therapy products available for us to use. You've mentioned Champix. Varenicline is the generic name. That was a treatment option we could use, and I say was because since June of last year, it has been unavailable to use because of manufacturing issues. So it continues to be out of stock. And a particular challenge is when patients have quit successfully, have relapsed and then return to the service asking to use a treatment that's worked so well for them in the past. And then unfortunately, we then have to say, at the moment, we can't use that particular treatment, but we have considered, we do use bupropion, which is Zyban, which is an alternative we're using whilst varenicline or Champix remains unavailable. But yeah, it is. So we have the prescribed medications we can use, but also, the nicotine replacement therapy. And it is patient choice.
So, and it's good to hear that you've got a wide range of pharmacological kind of options there as well. Because I think often when patients sometimes feel they need to refer to their GP surgery to get these sorts of prescribed options, and they don't always think that they can get them from self-referral services like Stub. So I think that's just something important for us to get across to patients as professionals, and for patients to understand when they're calling that really, you're going to offer a much better service than they'll get from their GP service, their GP practice. And in fact, we have patients sometimes who come and ask for prescribing around stopping smoking, and we always say, look, we cannot actually provide the right level of support around prescribing these products for you, and you really need to see the experts at Stub. So it's really just great to know that there's a lot of options there. And you've talked a number of times about behavioural support and how important this is. So what sort of things do you do in that area?
Okay, so as I say, we earlier in the consultation, we will have asked what their typical day looks like smoking wise. So they may say, I smoke within 5 minutes of waking up, when I flick on the kettle, make a cup of coffee, and then I have a cigarette. So we then ask the question, the open question. So we will ask them, so what do you think you can do to change that, just to break the link between smoking and the things you do on a day-to-day basis? So it's encouraging the patient to look at their current situation, their current day, and how they can change their own behaviors to help with a quit attempt and beyond our program, so that continued abstinence remains. And so it's more the patient drives the solutions rather than it being quite an instructive process. So yeah, I think it's important that the patients do get to reflect and think about their current behaviors and how they can be changed.
Good. Yeah, so I can see how it's
because no, sorry, because I just wanted about these behaviors will have to last.
Yeah.
They need to be lifelong behaviors, not just for the quit attempt. So yeah, it's important that they find the solution.
Good. And we often talk about motivational interviewing, as a technique in terms of behavioural change. And I guess that's about identifying like the motivating factors, why people might want to be doing things, and allowing people to engage with that. Is that part of it as well? Kind of exploring that side?
Yes. So, it's a really important question. We always ask why a patient wants to quit, what drives their motivation to quit. And, as we would all expect, health is always one of the major factors, whether it be a recent event in their health that's triggered the connection with Stub, or just ongoing issues that have slowly progressed. A big consideration now and for a number of years has been expense. I think we need to, we all know it's not the cheapest habit. And so finance is often a driver, and especially in the current climate, cost of living is increasing. So yeah, at the service, we don't particularly mind what the principal driver of motivation is. The important thing for us is that they have access to the service and they want to stop smoking.
What's the most common barrier that people face, or challenge that they seem to face when stopping smoking, in your experience?
I suppose
that's stuck with you? Go on.
I suppose fear of failure tends to be, and at that point, we always comment that patients don't, may not always quit at that particular attempt, and sometimes it can take a series of attempts to ultimately reach that point where the motivation is there. All social circumstances, for example, may be in place, and it may be just that one final attempt where they will quit. And sometimes, if the people around them are smoking, that can be very difficult. With the service, we always encourage all household members to quit. If there are others that smoke in the household. So that can be a particular challenge. But again, in some patients, the motivation has been so strong that even if their partner or family do smoke in the same household, it has not bothered them. So, that can be really pleasing to see as well.
I know I always, with most behavioural change issues, be that sort of cigarettes or alcohol use or other drug misuse, and often actually just healthy lifestyle behaviours like exercise and eating habits, that kind of the social norming of these things within certain families or groups of friends or groups of people seems to be like one of the biggest barriers to me as well. I see that a lot, and often people don't change unless the whole group does it, or for more extreme behaviors or substances, if they remove themselves from those groups of people that engage in those things. A bit extreme for cigarettes perhaps, but
But
I see that as well.
it is an important point to consider, in that a lot of patients have only known smoking. The smoking has been in their family for 2 or 3 generations, for example. So, as you say, sometimes it is the accepted norm in maybe that household or that locality. So, yeah, hopefully we're driving change in that respect.
Yeah. So just sort of stepping back and being perhaps a little bit more philosophical about things, what are the challenges that that either you've encountered or you see happening, in running and working within a service like Stub?
Yeah, so we touched on a little bit earlier in that the pandemic drove the service from being face-to-face, in-person consultations, to them being completely virtual. And we're slowly now increasing our capacity back to face-to-face consultations, but still acknowledging that the convenience of telephone or virtual appointments is still really important to patients. They all lead busy lives. This is a service that's provided to all of the city, and geographically, there can be some distance in coming from, where they live into Upper Parliament Street or Angel Road. So, yeah, there are those sort of practical barriers to overcome sometimes. So, and pragmatically or philosophically, we can only have a limited amount of input in the quit attempt. As I say, we give the advice, we've trained, we can steer patients in the direction they have chosen, with behavioral impact, with treatment choices that we've agreed. But after the consultation, it is up to the patient to follow up on the discussion and everything we've talked about, and, for example, quit on the date we've chosen. So there are those challenges, and also, the one particular one is not having a treatment option that was available to us that was successful in Champix. So that stock issue, we've still not heard anything regard
Yeah.
to resolution of that particular issue. Again, that is sometimes an issue, and especially where patients have quit successfully, having used it previously. So that can be a problem. And also, we're seeing an increased demand, maybe wrong, but we are seeing more and more patients ask us about support, and just behavioural support, no treatment, with regards to reducing or weaning off their e-cigarette use. That seems to be a more and more common question we are starting to get asked. So, as I say, unfortunately, this service is only for tobacco smokers. And so there does appear to be a little gap there that we need to think about, or the systems above us may need to consider to help that particular group of patients.
Yeah, e-cigarettes are a really growing sector, aren't they? I'm beginning to see lots of vape shops, all over the place. So both locally in the area where I practice and in Nottingham city centre. And I think the sort of medical community or the smoking cessation community in this country have sort of initially been quite positive about them. But I do worry that we're creating the next problem because they do seem to be becoming so popular. Yeah, but it's interesting, but maybe a conversation for another day. So hearing some frustrations there, particularly when patients, don't successfully quit, and it'll be frustrating for the patients as well. There must be some positives about working within the service, or some successes or success stories. Any of those to share with us, Deepak?
As I say, you often see, you have patients referred, where they've recently been discharged from hospital, with a serious health complaint or issue. And to her, and, sometimes patients can be, quite desperate to quit, and to help them along that journey. And, when they have stopped, and, when they do say, "Oh, thanks, you've helped me with this," and I always say to them, we're here to guide you. All we've done is guide you, given you some information. You've come up with the solutions. You've decided what you want to use to help yourself quit, and basically, you've done all the hard work. But even after 2 or 3 appointments, patients do start to feel well, or better. They maybe can, their physical activity, can increase ever so slightly with each appointment. They do notice the differences that stopping smoking makes from quite an early stage. And just to set them off at the end of the program, having quit, to a lifetime of not smoking from then on. It's really rewarding. It's really rewarding. There's a great team here, and working within such a good team is really, really good.
Good. And just so it does sound like it's really rewarding when people quit, and often patients are really, really grateful for the help they receive. So that is really, really positive part, working within a service like that. Just listening to the scale on the service, and the design and the structure, I guess a lot of clinicians and patients might not realize how much support there is, available from a service like Stub. 6 30 or 15-minute appointments, it's really, really good, with options for prescribing, some evidence-based behavioral interventions in there. That's really, really good. So I think we all should start making, more use of it, I guess. And maybe we will after this podcast. What are the capacity levels and waiting times like within Stub at the moment, Deepak?
So from initial referral, the aim is to make contact with the patient as soon as possible. On average, would say, maximum 7 to 14-day window. So patients do get contacted quite quickly and seen quite quickly.
That's good, because it's important to strike while the iron's hot sometimes with these things. Sometimes you have a window of opportunity, don't you, to get things started, with a behavioural change before some other challenge comes along in the person's life. So it's really important to keep those waiting times short, and hopefully they'll stay short, even if more people start self-referring or referring in to the service. Another question, just before we start to wrap up, I was just wondering, if you could, improve the service, and not, or smoking cessation, within Nottingham, and I'm going to say, budget's not too much of an issue, so you can do more. You don't have to operate within your existing budget. What sort of things do you think would be helpful? There might be some commissioners out there listening to this, for example.
Yeah. I suppose again, it's a challenge or barrier we do see is people having to come into the city. People can often be reluctant to do that for a number of reasons. So, taking the service to them, I would feel is the next step, and looking at, the hub and spoke model. It has been, discussed, and, preliminary investigations made into, the feasibility and, the logistics of operating on that level. Because I think it would just drive increased referral engagement, and I would hope quick success. And that, I think it's always, and I think, healthcare in general is starting to move, especially from a PCN level. It's about taking services to the patient rather than the patient then having to come to you. So yeah, definitely say expanding the service so that we go to where there is patient need.
Yeah, I think that sounds like a really fantastic idea, and I understand the rationale there. I guess something I'd like to see is perhaps a bit more publicity around the smoking challenge. I'm old enough to remember when we used to have more public health messaging, on TV and in papers. It was back then, and I see much less of that now. So just some general awareness, I think, would be really nice, and also some publicity around the smoking cessation services like Stubit that are available. Perhaps a bit more budget pushed into getting people self-referring and into the service, and then obviously you would need to expand the service to meet the increased demand that you drive as well. But I think if people are serious about smoking cessation in Nottingham City, then maybe that's what's going to be required. But that's my 2 cents worth as well. Deepak,
and also, I suppose a common question that you often get in consultations of the patients. They will have a consultation at Stubit, but then don't sometimes realise that we will prescribe treatments as well. So it's almost as if they expect to have a consultation with us, but then feel there is a need to then go to the GP and they will obtain a prescription there. And I do say, no, this is a completely, whole service where, we will talk to you, we will have the consultation, and we will supply you with the treatment. So that maybe that message could also be a little bit more prominent.
Yeah. So it's been great to hear about your own experiences within the Stubit service, and just learn a little bit more about the service in general, and in particular what happens and how people can get themselves into the service, or how people working within primary care general practice or the hospital sector can get people into this community smoking cessation service as well, and that people can receive treatments. We've lost Deepak. That's not a deliberate editing consideration to take him out of it. If we get Deepak back, I was going to ask him what next steps he would recommend. I think he's just popping back in. Let's bring him back on. Lost you there for a second, Deepak. I was just about to ask you, people have listened to this podcast now. What can they do next to make a positive step for Stubit or for their own health? What should people do next after listening to this podcast?
Okay. As I say, if people want to join the service, we are always looking for pharmacists to join the clinical pharmacy team. We're looking for smoking cessation advisors. So if they wish to join a really good team here at Stubit Service at NCGPA, get in contact with NCGPA and make inquiries in that respect. And with regards to promoting the service, as I continue what you're doing in your practices, in highlighting the service and the ease of access to the service, and wherever possible, if we could have patients self-refer, just to indicate their degree of motivation, that would be even better.
That's fantastic, and I know I'll be trying to spread the word amongst my my general practice colleagues, potentially sharing this podcast or YouTube video with them to educate themselves a bit more about Stubit and actually the comprehensive nature of the program of care delivered by Stubit when they refer somebody in, and that they can encourage patients to self-refer, which I think is a really, really important message. And I suppose finally, if there's any patients watching, we've just popped on screen the referral details, and for those people listening on podcasts, they can refer in by calling 0115 824 0583 and selecting option 2, and they'll be able to refer in via the ncgpa.org.uk website as well if they want to do that. I guess just a final thanks to you, Depak, for joining us, and thanks for people out there who've been watching or listening and learning. And we'll try and come up with some more topics. We've got a program of things we want to bring to you with NCGPA Live, so stay posted and look out for the next episode. Thank you. Goodbye, Depak.
Goodbye. Thanks, Andy.